Over the last number of years, it had been identified that there was an increasing number of frail elderly patients presenting to the emergency department here in Beaumont. These patients were spending longer time in our emergency department. As a therapy team, we were providing minimal service to the emergency department. So the FIT project was needed to come to the front door to provide assessment of need for these frail, vulnerable patients as they presented to our department.
We looked at the data, the throughput of patients coming through the emergency department. We identified what we were going to do, the age profile we were going to see, and what we were actually going to do on the acute floor. So we had a plan by the time we came to the emergency department. We then picked a date, 21st of September 2015, and we got down onto the floor and we started working, developing relationships with our ED colleagues, nurses, doctors, and all the other professionals involved on the acute floor.
Because the patient's needs are identified at the front door, it means that we can offer multidisciplinary expertise and contribute to the decision-making process in terms of safe discharge home or whether the patient needs to be admitted. This ultimately minimises unnecessary steps within the patient's journey.
On the front line, we had a multidisciplinary team that consisted of social work, occupational therapy, physiotherapy, speech and language therapy, pharmacy and dietetics, who all work closely with the ED medics and nursing staff.
So we feel the quality of care for patients has significantly improved. From our nursing colleagues at the front door, they triage for frailty and a marker comes up on the ED IT system. We then do our initial assessment, which we look for any markers for frailty. Has the patient's mobility reduced? Is there an issue with cognition? We would then, from our initial assessment, decide what therapists need to see the patient. Do they need a physical assessment by the physiotherapist or occupational therapist? Do they need a cognition assessment by the occupational therapist? Are there social concerns which we need to flag to our social worker? As a physiotherapist and occupational therapist, we would then do a joint assessment and we look at the patient's function, getting in and out of bed, walking, looking is there any risks of falls for the patient? Do they need an additional aid? After all of this, we would come back together as a team and make a decision based around the patient's needs, medical conditions, speaking with the nursing and the medical colleagues. Does the patient require an admission to the hospital for the medical issue? If not, we will do everything in our power to get this person home as safely and as quickly as possible.
They've taught us a lot. I think it'd be fair to say that everybody has gained from this whole project, really.
The need had been identified and the FIT team addressed the need. It's not the amount of patients that they see, it's not even the reduction in length of stay for the elderly patients. It's the quality and the professionalism of care that they provide in an incredibly challenging environment.
We feel that we are champions for the frail elderly and we want this project to be shared across the whole country so every frail elderly person can get their needs identified as they present to the emergency departments.